morbidity that needs addressing. Mm-hmm. Outside of that, ideally before colitis, ideally before marriage. Mm-hmm. If you don't catch them before marriage, then if you get them before they're pregnant, and you're doing routine gynecologic care and you notice that she's circumcised, you can at least begin to have the conversation and to discuss what does this mean to her, and if she has any thoughts about if she would want to have the scar open. Again, this is very much patient-led and patient-directed. Mm-hmm. If she's already pregnant and we find her she's cut, then during the second trimester is the perfect time to open the scar because you avoid the complications of labor and delivery where you may have a team that's not familiar, you may have emergencies and you have to place a Foley catheter, IFC, IUTC, and it might be difficult. So ideally during the second trimester of pregnancy because you avoid the anesthetic risk of the fetus in the first trimester or the third trimester. If she's now in labor, intrapartum, and she got into care late, and she missed the window to get her defibrillation done in the second trimester, so she's in labor, the best time to do it is likely in the first stage of labor, because then this could also facilitate cervical exams without discomfort. Maybe she might not want to epidural right away if she's a post-stage infection and is long, thick, and closed. You don't want to give an epidural that early. You could do a saddle block and then have anesthesia do a saddle block to do defibrillation, and then she can continue on with her labor course and induction with Cytotec or Cervidil, and then deliver vaginally. Or if some reason there's an obstetrical indication with fetal distress that she needs to have a C-section or emergent C-section and was going to get defibrillation, you can still do the defibrillation at the time of C-section. Mm-hmm. You do the C-sections over the baby, but still do the defibrillation right there and then. Where she's still under the spinal anesthetic or whatever anesthesia, you can still do the defibrillation then. Mm-hmm. Which often gets missed. It's like, oh, she had a C-section, so she didn't get it. Like, what? But you could have. Like, what stopped you from doing it right after the section? Like, what? I see that all the time where it's like, yeah, she had obstetrical reasons why she ends up with a C-section, but you could have still honored her request for defibrillation. Like, what was stopping you from still doing it? Mm-hmm. So that's a big soapbox of mine. Mm. But yeah, I think the timing is nuanced. It's not a one answer. It depends on the specific circumstance of the patient, which obviously would be adjusted depending on if she is young, unmarried, pregnant, not pregnant, suddenly married, in labor, first stage of labor versus, after pushing. So, there are all the scenarios based on when you see the patient and what are the other contextual factors you need to consider. Mm-hmm. Yeah. But most importantly, there should be anticipatory guidance so that the provider, no matter where and how and in what context you see the patient, that should always be in the presence of mind to make sure that counseling happens whenever it can happen, to make sure you plan accordingly to optimize the outcome for the mom, for the woman.
Mm-hmm. Great. Okay, wonderful. Now, let's see. I have to read through my question guide, Krista, because you've covered so many of them. So one of the questions that you've touched on in a lot of different ways, but I want to pose it again in case there's more you want to add. But what are some of the clinical practices by healthcare providers that you think might be worsening the health outcomes for women and girls with FGC?
Worsening is lack of competence among providers. The sheer lack of competence, the sheer unwillingness to learn, the sheer unwillingness to let go of their biases. Offering C-section just because you don't want to deal with that. Like, it's a strange thing. You need to, I was a resident when they literally said we do a C-section to protect our culture. This is our culture, we're protecting it. That's why we do the C-section. I was like, what? It's not explored. But one of my attendings told me that. That's why they get cut. So yeah, it's a sheer incompetence. Sorry. It's worsening outcomes. And massive distrust. Doing C-sections for non-obstetric indications.
Yeah. You've given me some wonderful quotes, Krista. Don't worry. It's all anonymous, but there's some great nuggets in here.
I get so often, that I say, it's like sheer incompetence, truly.
Yeah. That's why I wanted to do this interview. I want your voice and these quotes to make it into so much of what we're going to be writing up. Anyway, okay. And then a similar question, but the opposite. And again, you've touched on this in a lot of different ways. But any additional clinical practices that you think could be improving the outcomes for women and girls with FGC?
I've said this many times.
You don't have to repeat, but just sometimes asking the question again, it triggers something else. And if it doesn't, that's okay. I have more.
Yeah, I think I'm good.
Okay.
I've kind of touched upon it quite a bit ad nauseum.
Okay. And let's see, we talked about defibrillation. So you talked about defibrillation, clitoral reconstruction, reinfibulation. Are there any other surgical procedures that you think healthcare providers should be aware of related to FGC?
Those are the big ones.
Okay.
Those three. Yeah, those are the big ones.
Okay.
I've already touched upon the clitoral reconstruction. Yeah, those are the big ones.
Okay, great. Okay, so then what do you think the role of healthcare providers is in terms of the abandonment of the practice of FGC?
Oh, that's a good one. So we're really aiming at protecting girls. I would say, especially in this current political climate, not distancing ourselves, building, nurturing, and sustaining trust so that patients will still seek care, so that would provide an opportunity for us to have dialogue with the moms, engaging the husbands, engaging the fathers as well. I think a lot of times we focus just on the women as though it's a women's issue, and men are all the bad, evil ones that impart these patriarchy. But no, men are important critical partners as heads of their household, as husbands, as fathers. They care about their daughters and their wives. They don't want their daughters and wives to suffer and have pain. In fact, this is a very patriarchal practice, and oftentimes if we engage men in a more meaningful way, I think we would also advance efforts to eradicate this practice. So I'd say the two big things providers can do is engage the fathers and brothers and husbands, community leaders, and religious leaders, and then make sure that we are nurturing and sustaining trust, keeping that patient provider door of communication open, so that in this, especially in this political climate where there's such backlash towards refugees, immigrants, and religious minorities, that we can maintain that door of trust, that we're not there rounding people up to criminalize them and deport them and get CPS, remove their children from their home, that we want to create an environment of trust where patients can seek evidence-based care and proper education and counseling that will help them keep their daughters safe and engage with social service and other services as needed. But really the goal is to really protect families and empower them and give them education in a trusted environment, safe space.
Yeah. Great. Is there anything else related to healthcare provider practices that you want to add before we move on to talk about attitudes?
No. Is attitude the last section?
Yes, it is. And really a lot of these questions you've already answered, so feel free to just to pass or say if you feel like you've covered it completely. So and if you have time limitations, Krista, let me know, because I also can sort of reformat how I ask these if we need to wrap it up.
Because I do need to wrap up to go pick up my daughter, that's why.
Okay. So
I'm hoping it wouldn't take too much longer.
Yeah, no, so a lot of this about attitudes you've really addressed already. So I'll frame a couple of these questions. Okay. I'm just reading through. I want to see what are the ones that I most want to hit, because a lot of this you really have answered. So, okay, tell me please, what do you think about the practice of FGC?
Tell me what? I'm sorry?
What do you think? What is your attitude towards the practice?
Personal.
Personal
that's
attitude.
A good one. Yeah, my personal attitude is that we need to be protecting all minors, all children, regardless of gender.